When discussing heart conditions, you may have heard the term stable ischemic heart disease. That name is now evolving, with experts preferring the term chronic coronary artery disease, or CCAD. This condition is defined by a long-term imbalance between the heart muscle's demand for oxygen and its available supply, which is typically caused by the atherosclerotic obstruction of the coronary arteries. Understanding how clinicians approach this condition begins with the initial workup. For a patient without a known history of coronary artery disease, the most common presentation is stable angina. While a coronary catheterization provides the clearest picture of the coronary anatomy, it's an invasive procedure and isn't necessary for everyone presenting with chest pain. Instead, the diagnostic journey often starts by determining a pre-test probability, which estimates the likelihood that a patient's symptoms are actually caused by CCAD based on their age, sex, and the nature of their symptoms. To refine this probability, a tool called a coronary artery calcium score, or CAC score, can be incredibly helpful. This is a quick 10-minute scan that doesn't require any contrast dye, though it does involve a small amount of radiation. It's important to note that a CAC scan only reveals calcified or hardened plaque. This means it isn't perfect, as it can miss softer, non-calcified plaque. Because of this, even a CAC score of 0 still carries some level of risk. However, a score of 100 or greater bumps the likelihood of obstructive disease to at least 15%, and a score of 1,000 or more raises that likelihood to 50% or higher. Essentially, the CAC score helps move patients from a maybe category into a more likely or less likely bucket, guiding the decision for the next step. The results of this pre-test probability directly inform the next phase of the workup. Patients with a low pre-test probability, meaning less than 20%, generally don't require any further imaging. Their symptoms are likely due to other causes. On the other end of the spectrum, those with a high pre-test probability, or greater than 80%, are often referred directly for invasive coronary angiography. The most interesting group falls into the intermediate range, between 20 and 80%, as this is where further non-invasive testing provides the most value. For these intermediate risk patients, the choice of test often depends on their specific profile. A coronary computed tomography angiogram, or CCTA, is the preferred initial test in younger patients, typically under 65 years old, who have chest pain of an uncertain cause. This test provides excellent anatomical detail, showing not only how narrow an artery is, but also the characteristics of the plaque itself. It's less useful in patients who already have stents or heavy calcium buildup, as these can make the images difficult to interpret. For older patients or those with a known history of coronary artery disease, a functional stress test is often preferred. This could be an exercise stress echo or a nuclear scan. The goal here is to assess the physiologic consequence of a blockage by making the heart work harder and watching for signs of poor blood flow or ischemia. It's a crucial insight that up to 30% of patients with angina symptoms actually have ischemia with no obstructive coronary arteries, a condition known as INOCA. In these cases, microvascular dysfunction or vessel spasming are often the culprits, and specialized tests can help confirm the diagnosis and guide therapy. Once a diagnosis is established, the management of chronic coronary artery disease is guided by two primary goals: preventing major adverse events like heart attacks and strokes, and improving symptoms, mainly angina. It's critical to remember that not every treatment accomplishes both of these goals. The fundamental principle for stable disease is to treat every patient aggressively with medication and lifestyle changes. More invasive procedures, like stenting or bypass surgery, are reserved mainly for controlling severe symptoms or for specific high-risk anatomical situations where surgery has been proven to improve survival. To prevent bad events, several medications form the cornerstone of therapy. Low-dose aspirin, between 75 and 162 milligrams daily, is recommended to reduce the risk of heart attack and other cardiovascular events. All patients with CCAD are considered to have clinical atherosclerotic cardiovascular disease and should be on a high-intensity statin. The goal is to lower LDL cholesterol, with guidelines setting a target of less than 70 milligrams per deciliter for most patients and an even lower target of less than 55 for those considered very high risk. If a statin alone isn't enough, ezetimibe is added next, followed by a PCSK9 inhibitor if needed. For patients who also have type 2 diabetes, SGLT2 inhibitors and GLP-1 receptor agonists are now a standard of care for reducing cardiovascular risk, regardless of their blood sugar levels. When the focus shifts to relieving angina, the medication strategy changes. Beta blockers are the first-line treatment, as they reduce the heart's oxygen demand by slowing the heart rate and decreasing the force of its contractions. If angina persists, calcium channel blockers or long-acting nitrates are considered second-line options. A third-line agent called ranolazine can also be used. It works through a unique mechanism that doesn't affect heart rate or blood pressure, making it a useful option when other medications are limited by their hemodynamic effects. Finally, we have revascularization procedures. For most patients with stable angina, a percutaneous coronary intervention, or PCI, does not reduce the risk of death or future heart attack when compared to medical therapy alone. Its primary benefit is symptom relief. Therefore, PCI is typically reserved for patients whose angina significantly limits their lifestyle despite being on maximal medical therapy. In contrast, coronary artery bypass graft surgery does offer a survival advantage for specific patients. This includes those with complex disease in multiple vessels, disease in the critical left main coronary artery, or those who also have diabetes. Once a treatment plan is in place, ongoing monitoring is key. This involves regular lab work to track risk factors, such as a lipid panel, about 4 weeks after starting or changing a medication, and at least yearly thereafter. However, a crucial point is to avoid routine, repeat anatomic or ischemic testing in stable patients who haven't had a change in their symptoms. This type of repeat imaging is not recommended simply for risk stratification and doesn't typically change the course of therapy. Instead, the focus remains on optimizing medications and lifestyle to manage this chronic condition effectively for the long term.